Okay, I want to talk about blood pressure medicines, but I'm going to talk about two flavors of the way to take it. One is you've got high blood pressure. And so taking blood pressure medicine for that kind of makes sense, and I want to talk about that. There's a more subtle reason that specialists, particularly cardiologists and medical doctors, can give high blood pressure medicine, and that's for a kind of heart failure problem where they're trying to get afterload reduction, even though the patient may not have high blood pressure. So I want to go over the routine kind of high blood pressure medicine and how we manage it post-op, and then come back and talk about afterload reduction in heart failure and how we'd like to look into managing that with the Atacand post-op. Okay, well, simply, just a real quick overview, I'm not taking too long. People who have high blood pressure have more frequent heart attack, stroke, and death. So, all across the United States, there's a huge effort to identify people with high blood pressure and bring it down. Generally with medicines, although diet and exercise has been shown to be quite effective also. And generally the first thing that a physician is supposed to tell their patient is try eating a low-salt diet, exercising every day, eating something called the DASH diet, which is fresh fruits and vegetables and things like that. And if those things don't work, the next thing is a medicine. And right now the number one medicine to use if you have high blood pressure is, in the old days, back in the 1800s when I went to medical school, it was a diuretic. They can still use hydrochlorothiazide as a first step, step one, but there's a lot of people who like what's called the ACE inhibitors. The ACE inhibitors are now generic, so they're real cheap, so the drug companies have come up with something that's like an ACE inhibitor called an ARB. ACE inhibitor is a angiotensin converting enzyme inhibitor, and an ARB, the new one, is an angiotensin receptor blocker, and those are kind of first two steps. We used to use other drugs like beta blockers and calcium channel blockers, and we use them less today, would you say? They're more like backups. But bottom line is high blood pressure is bad, treating is good. Lots of people are treated because lots of high blood pressure, and we think that'll make a huge difference throughout the country in saving people from heart attack, stroke, and early death. Now, having said that, when I look at my patients, close to half of the people who come to see me have high blood pressure. So how many with high blood pressure? Okay, there you go. Oh, one. Thank you. She didn't have that. She was just being nice. But it's pretty common in my patients, pretty common in the United States, and so many of my patients arrive on high blood pressure medicine, and the question arises how to manage that post-op. And I'd like to give you who are watching the video, as well as those of you here this morning, our plan and the reason behind that, because most of the time we withdraw your high blood pressure medicine in the post-operative period, have you get a wrist blood pressure cuff and monitor your blood pressure regularly, and we expect that our patients post-op will have slightly high blood pressure for the first several weeks, and maybe even the first several months. It may be worthwhile to point out that high blood pressure, like smoking, doesn't kill suddenly. Having high blood pressure today is not like shooting yourself in the head with a gun. You pull the trigger, you die. High blood pressure kills like smoking does over decades. So my patients who have the surgery and we withdraw their blood pressure medicines, often in the first week or so will have high blood pressure. We prefer that because we can't stand the opposite, which is low blood pressure. So let me see if I can explain that. People who come to me on high blood pressure medicines come to me prior to surgery filled with extra fluid, edematous, swollen, and have high blood pressure. And after surgery, the MGB itself is a powerful therapy that drops your fluid and drops your blood pressure, but does it on an unpredictable slope of decline. If you think of the temperature going from summer to winter, you know that if you measure that temperature every day, it has ups and downs. And even during the same day, it might be sunny during the day but have a cool winter night. Imagine if that track of temperature was your blood pressure. And imagine if that drop occurred when you're standing at the top of a series of metal stairs that's 2 stories high, or if you were piloting a jet airplane, or some other situation where a little bit of too low blood pressure could lead to a tragedy or death. So we see patients who come to us with high blood pressure, who are on high blood pressure medicines. We know that the MGB is going to decrease and cure high blood pressure in many, if not all, of our patients. And we fear that the combination of the blood pressure medicine plus the MGB can result in episodes where patients get blood pressure that's too low. In fact, we've had that. We had a patient from North Carolina walking on the sidewalk downtown, and he fell and broke his hip. Now, that's just, he went off the curb and broke his hip. Imagine if you're up on the top of stairs or something else. So in general, for our high blood pressure patients, we like to keep the high blood pressure slightly high rather than seeking the optimal, slightly lower blood pressure, because we fear that the power of the MGB, like the temperature going from summer to winter, is going to increase over the coming 6 months. And if you're not meticulous, or if it's just unlucky, you can wind up with one day, a week from today, a month from today, where the blood pressure will be so low that you fall down. And if you hit a sharp angle, all of a sudden you have a tragedy on your hands. So we want to treat high blood pressure. We want decades of low blood pressure. We expect that's on the way because we see a high cure rate, but we fear trying to cure it too quickly with the medicine and the MGB. I have hundreds of phone calls from patients who've gone back to their good local medical doctor. They've had their blood pressure measured. The doctor has said, you have high blood pressure still. The patient says, Dr. Rutledge wants to hold my high blood pressure medicine. The doctor says, but your blood pressure is 140 over 100. You need to go back on it. And a week later, they're laying on the floor and can't stand up. Okay? Because the MGB is coming from here to there. So, in general, we prefer to leave your blood pressure, in general, normal to slightly high in the coming weeks for your safety. Okay? Perfect is the enemy of good. Trying to get that adjusted in the first weeks and months after MGB with the arrival of the very powerful therapy of the MGB as a combination can, we think, in rare cases, be dangerous and deadly. So that's for high blood pressure patients. Remember, though, I had something else I wanted to talk about, and that's the use of high blood pressure medicines in heart failure patients where their blood pressure is already relatively low. And this is well studied in using ACE inhibitors and now the ARB drugs, where they say the heart is pumping. If you could take down the resistance it pumps into, even without changing the blood pressure much, those heart failure patients do better over the long term. You're unloading the heart, and the heart can't stand that load. Okay? Makes perfect sense. We support that. But again, remember that in the background of the heart failure patient that's being treated with an afterload reduction agent, the MGB is coming. Okay? Just like Paul Revere rode his ride, the British are coming, you know, to wake up every village, Middlesex town and farm, that this is the... Okay. Let me tell you, the MGB is coming. And if you take afterload reduction and overdo it and overdose it, all of a sudden the heart failure patient can similarly have a low blood pressure and can suffer stroke and other complications that can be deadly. So again, even in the case of afterload reduction and the use of medicines like ACE inhibitors or ARB, angiotensin receptor blockers, we prefer to be on the very, very conservative side. Again, perfect is the enemy of good. Our patients' hearts over the next year improve remarkably. Okay? We see patients with heart failure get rid of heart failure. We see patients who have poor ejection fractions, ischemia, hypertension, pulmonary hypertension, and other signs of heart dysfunction improve tremendously. And what we want to warn our patients in this video and you're here this morning to say, beware of using the MGB, which is powerful therapy, plus Any kind of drug which lowers blood pressure or lowers resistance. Over time, my patients call me and say, I passed out today. My blood pressure was 90/60. The MGB lowers blood pressure powerfully. It causes a massive diuresis. That's medical terms for you pee your brains out. But much better billing when you say massive diuresis. So beware and understand that when you get the MGB, you get a therapy of tremendous power, and you have to have a tremendous respect for that. If I knew that a rattlesnake lived in my front yard, every day when I came out in the morning, I would be heads up. I would be alert. I wouldn't be coming out in flip-flops looking up at the sky. Okay? The MGB, I want to inform you, I want to emphasize to you, is tremendously powerful. We see people with heart failure who can't walk, who can't breathe, and they get better. We see people with severe pulmonary hypertension, with severe right heart failure, and that changes tremendously. All of a sudden they're bowling and rollerblading and doing all kinds of things. The MGB and what it does to the vascular system is remarkable. Beware that you ignore that and treat on today's experience, because we found that you can overtreat. Call me. So, restarting the attic.